Okay, here we go again. I took a break because the battery died on my computer. As you guys know, I'm not too computer savvy, but luckily my wife saved the day. So we talked about when somebody has a panic disorder, they sometimes self-isolate in their home or wherever because they're afraid of having an embarrassing panic attack in public. And this isolation makes the disorder worse. Again, we need other people. Let's go on to the next one. Obsessive-compulsive disorder, known as OCD. These are unwanted, repetitive thoughts which cause anxiety, followed by a compulsion, which is a behavior to relieve that anxiety. Interesting enough here, there may be some association between rheumatic heart disease and obsessive-compulsive disorder. Again, we don't see rheumatic heart disease much anymore because of antibiotics, but they noticed that children that had rheumatic heart disease sometimes afterwards displayed OCD behaviors. There was actually an article in a journal many years ago of a patient who had severe OCD. Unfortunately, he tried to commit suicide and he survived. He got rid of his compulsions and obsessions, which indicates that this is caused in the brain by parts of the brain. I'm sure this person, though he got rid of his obsessions and compulsive, I'm sure had other parts of brain problems from the trauma of trying to hurt himself. But let's talk about mild obsessive compulsive disorder. It's actually a benefit in our society many times. So mild OCD lends itself to higher functioning people in our society because our society is becoming very detail oriented. In other words, a physician, an engineer, a computer expert. These are very precise professions. Okay. In the old days, if you were a farmer and farmed the field 5 feet to the right and the next year's 3 feet to the left, it didn't make a difference. But nowadays, with science and everything having to be so exact, accounting again, engineering, nursing, there's a benefit to mild OCD. One of my jokes with you guys is, so if you're not a neurotic OCDer yet, we will make you one. Okay? So our job as nursing instructors is to make you aware of detail, checking what the drip rate of the IV is, checking it several times, the 3 checks of med administration, the 5 rights, being neurotic about administering medications. Common symptoms of OCD. Obsessions, again, these are the thoughts, very common, a fear of contamination. This might make sense, especially nowadays with the coronavirus. Your fear of being contaminated, so you wash your hands. So we can almost say that some of these mental disorders are survival mechanisms gone awry. Okay, a fear of hurting others. Many times, most times, these obsessions are said to be ego dystonic. In other words, the patient does not like them, but is compulsed to do the behavior. Okay. So again, compulsions here, this is the physical action of checking, counting, ordering, washing, praying. It might be that you're a person with a little OCD, like myself. Sometimes I'm driving to work and I think that I turned the gas off on the stove. Occasionally I have left it on, which makes me more anxious. So I call up my neighbor across the street and he comes over and makes sure the gas is off on my stove. I'm trying to protect myself and my family. Okay, so again, a severe form of this is a survival instinct gone or a survival instinct gone awry. Acute stress disorder. Person has recurrent thoughts of a stressful event, is unable to mobilize. This can last days to months. You're in a horrific car accident and you don't want to drive, but little by little you get up the courage to drive again. So acute distress, maybe not even pathological. Again, if you're mobilizing and slowly climbing out of it, if you stay stuck there and you can never drive again, it is truly diagnosable here. PTSD, post-traumatic stress disorder, similar signs and symptoms to acute stress disorder, but symptoms appear months to years later. May also have as a symptom here hypervigilance, anger, and risk-taking behaviors. I know when I worked with veterans many years ago, a Vietnam vet said after the Vietnam War, him and his buddies would get drunk and play Russian roulette. If that's not a risk-taking behavior, I don't know what is. But what's interesting here is he would tell me when the gun didn't go off, he would feel so alive. And that made me think about battle and combat. Coming out of battle and combat, there's a rush of adrenaline. Again, I've never been in combat, but I'm sure your adrenaline is cranking out. So in some sense, he may have been mimicking his past experience of combat by playing Russian roulette. A phobia. Again, this is an irrational fear of a situation or object that manifests with severe anxiety or panic beyond what would normally be called for. For example, you see a mouse run across the floor and you scream. That's a bit of an overreaction. That's a phobia. There are three basic types of phobia. Simple phobias, fear of a specific stimuli, spiders, dogs, something that triggers it. Social phobia, this is actually a diagnosis in the DSM. It is severe shyness, and the underlying fear here is to be publicly humiliated. Okay. Agoraphobia, claustrophobia, virtually they're the same thing. The fear here is being unable to escape. The term agoraphobia came from agriculture, open markets where people in yesteryear and maybe places upstate, they go to these open markets where people are selling produce and there's crowds of people, and for some reason they feel there's too many people and they can't escape. That would be equivalent of putting me on 42nd Street amongst many people. I tend to get anxious and need to get out of there quickly, as my wife will tell you, and my son. So there's another type of anxiety disorders called somatoform disorders. If you remember, soma means body. I believe it's Greek. Okay. These are physical symptoms in the absence of a true physical illness. Somatization disorder, various complaints of many body systems. For example, somebody comes to the ER and says, I have the prostate cancer, I have lung cancer, I just got diabetes, and I have a broken leg. That would be unusual to have somebody come in with all those ailments all at once. Okay, so probably underlying anxiety. Hypochondriasis, person believes that they have a specific serious illness with no evidence of that disorder. So they are similar. Somatization is multiple illnesses. Okay, again, they're not real illnesses. They are manifestations of anxiety. So they're somaticizing, blaming it on a body function. Body dysmorphic disorder, excuse me as I take a sip of water, is a preoccupation with a mild or imagined body defect. There is certainly an OCD component here. The person is constantly thinking about it. Okay, even if there is a mild defect here, in the person's mind's eye, the defect appears much bigger than it really is. But they think about it a lot. Okay, another disorder here called pain disorder, pain that cannot be attributed to any other disorder. Again, they feel pain, but it's not due to something physical, it's anxiety manifesting as pain. And of course here we would not use opiates. The problem here is, how do you measure pain on somebody? Pain is subjective. One of the ways I do it, again, I've worked with addicts for a long time, and addicts by definition are med seeking. That's the definition of their illness. They may be seeking painkillers. So what we can do as nurses is, one, we observe them from afar. As I've told you guys many a time, you should be out on the unit 15 minutes of every hour. Get from behind the desk, go mingle with the patients. If a patient is sitting watching TV, relax, and then 5 minutes later he comes to the front desk and says, I have pain, I need an opiate, he's probably not in pain, it's probably anxiety. Another way to measure pain is the facial scale. Again, a person in severe pain is grimacing. Okay, third way to do this is to do the scale on 1 to 10. We ask a patient on a scale of 1 to 10, what is your level of pain? If they tell you their pain level is 10 while they're talking to you, it's not a 10, because someone with a pain level of 10 is literally in bed wreathing and sweating in pain. So there are ways to assess pain. Again, we have to do it without the patient knowing that we're observing them many times, because they can try to feign the pain symptoms. There's a type of anxiety disorders called dissociative disorders, and like I said earlier, this is a fragmented psyche. One of these disorders is called dissociative identity disorder. The person creates subconsciously, this is not conscious, an alternate personality. Okay, this is commonly known as a split personality disorder. Okay, in terms of DSM, it's called dissociative identity disorder. And many times this is due to severe childhood trauma. Okay, children can endure traumas intermittently. Life is difficult, life is complicated, but severe, unremitting, where the child never feels safe. Okay, the psyche is fragmented. Dissociative identity disorder. Dissociative fugue. Don't ask me how they get the spelling of fugue out of F-U-G-U-E, but anyway, that's the way it's spelled. In this case, the person abandons their routine and forgets their identity, or may take on a new identity. More commonly seen after war or other traumatic events. In fact, many years ago when I first started teaching, one of the students had said that her uncle was involved with the Twin Towers. They thought he was deceased. He was gone for a week or two, and one day he appeared at their doorstep in Glen Cove. And they said, "Where have you been?" And he said, "I don't know. I don't know." So he may have been suffering from the one below here, dissociative amnesia, where the person forgets about personal information about a traumatic event. Once again, it's the brain trying to protect itself from this trauma. Let's talk about medicinal treatment of anxiety. Well, we know that benzodiazepines are very good anti-anxiety agents, but we also know that they are prone to addiction and abuse. So for intermittent anxiety, once or twice a week, a benzo would be indicated. Ativan, I don't like Xanax, it's very short acting, which makes it more prone to addiction. Ativan, Klonopin, things like that would be a good choice. Another anti-anxiety agent is called buspirone, brand name Buspar. It's not a benzo. It actually works on a serotonin subtype receptor to decrease anxiety. So you can think of Buspar as almost an SSRI that doesn't have mood elevating properties, it just has anti-anxiety properties. SSRIs, on the other hand, they reduce anxiety and also elevate mood. Again, we noticed this many years ago when you gave somebody Prozac for depression. We noticed that their anxiety decreased also. We have to be a little careful with Prozac, though, because Prozac can be activating. So if somebody had an anxiety disorder and we wanted to treat them with an SSRI, we'd probably go with Zoloft or Lexapro or Celexa or maybe even Paxil. But SSRIs are the drugs of choice for treatment of chronic anxiety because they're not prone to addiction and abuse. On the other hand, you guys might remember tricyclic antidepressants known as TCAs. Again, effective for anxiety and mood, but have many side effects. We spoke about them: anticholinergic, such as constipation, adrenergic receptor blockade, which means when you block the adrenaline receptor, you can get orthostatic hypotension, meaning when you stand up, you can get dizzy. You could possibly fall down and hurt yourself. So again, the TCAs are older medications, effective, but we have much cleaner ones, the SSRIs. When I say cleaner, I mean less side effects. Also, antipsychotics can be used also. I think a better term for antipsychotics would be major tranquilizers, because if you tell somebody with anxiety you're going to give them an antipsychotic, they say, "No way, I'm not taking it, I'm not crazy." Okay, so it's again, how does the nurse present the medication to the patient to have them take it? The doctor writes the script and goes home. Our job is to have this patient take the med. And the way we present it to the patient is important, because if we present it the wrong way, they're not going to take it. So antipsychotics, by decreasing the effect of dopamine, you might remember, they block the dopamine receptor, dopamine being an excitatory neurotransmitter. When you block the effect of it, you calm somebody down. They are quite effective and quite safe. Okay, let's talk about non-medical treatments, behavioral treatments for anxiety. And these should be tried before medication. Or if the person is unable to try these because they're so anxious, we could add a medication. I should say not us, but the doctor or the nurse practitioner can add a medication so the patient can practice these techniques. One of these techniques is called biofeedback, and really what this does is it teaches people that what they think can affect how they feel physically. The biofeedback machine measures pulse, your blood pressure, diaphoresis means sweatiness, your skin temperature, and brain waves. Okay, by having this feedback, people can learn to relax themselves by thinking positive thoughts. What will happen is a therapist will hook the patient up to this machine, and the therapist might say, "You're at the beach, it's a beautiful day, the sun is setting, you're walking your dog." And the patient looks at the screen in front of them and they see their blood pressure go down and their heart rate goes down. So now the person begins to realize that if they can think calming, relaxing thoughts, they can actually calm themselves down. It's called biofeedback. Well, interesting here is the lie detector machine is virtually the same thing as a biofeedback machine. In a lie detector machine, they're measuring sweatiness, blood pressure, and pulse. What they do is they ask you some benign questions, such as, is your name Michael Mangino? And you say, yes, it is. When were you born? On July 21st, 1959. Okay. So they've got a baseline now of how you react with neutral questions. Then they ask you the fateful question. Where were you on the night of July 9th? Were you at the bank on Fifth Avenue? And you say, no, I wasn't. And if you were really there, they see your blood pressure go up, they see your pulse go up, they see your sweatiness go up. Remember, all the things I just spoke about are caused by adrenaline, because when you're under stress and you're lying, you release adrenaline, which makes your blood pressure and pulse and sweatiness go up. So there's a medicine I might have spoken about that you could take that would trick the lie detector machine to not display your anxiety. Think about that for a second or two. Well, this medicine is called propranolol, also known as Inderal, the brand name. It is a beta adrenergic receptor blocker. In other words, there are many subtypes of adrenaline receptors on the postsynaptic nerve. And if I had the blackboard, I would be drawing at the synapse, which you guys know I love to do. Well, when you bind something to that receptor, in this case propranolol, their adrenaline can't get to it, and their vital signs do not escalate when you ask them the question of where they were on the night of July 9th or whatever that date was. So you could actually trick the machine by taking that medication. Another technique we can use here is called systematic desensitization. This is slow exposure to anxiety-producing stimulus. For example, if someone has agoraphobia and is afraid to go outside because they might get anxious, the public health nurse would stop by this person's house and say, Mr. So-and-so, today we're going to open your front door but leave the screen door closed and just sit inside your house with the door open and look outside. The person calms down, you come back a week later and say, Mr. So-and-so, today we're going to open up the main door, open up the screen door, we're still going to sit inside. And you do that for a week or so, the person calms down, the next week you come back, and now you say, we're going to sit outside on the stoop. And you do this over time, systematically desensitizing the person to the stimulus that is causing the anxiety. Another technique here is called deep breathing, also known as Lamaze breathing. Women use it when they're giving birth. What we do here is several ways to do it. I've heard 4 seconds inhale through the nose, hold for 4 seconds, and exhale through the mouth for 4 seconds. Doing that over time, we can calm down. Again, I've heard women say, Lamaze breathing, forget about it, just give me the morphine, enough of this. That's a personal decision, no right and wrong there. Another technique is progressive muscle relaxation. Beginning at the feet, we tighten each muscle group, progressing toward the head. So you tighten your feet, you tighten your calves, you tighten your thighs, and we do this over and over to help get rid of anxiety. Another thing I want to add here also is they're finding exercise is one of the greatest anti-anxiety treatments we could have. Also, it's one of a very effective antidepressant treatment. They've actually done studies. Regular exercise of about 20 minutes, at least 20 minutes every other day, to the point of sweating, you have to sweat, equals about 150 milligrams of Zoloft, which is a pretty decent dose of Zoloft. Again, Zoloft is an SSRI antidepressant. Another technique here, meditation. The person concentrates on breathing, an object or a word. The word is called a mantra. Some people just go om, om, and you let your mind float. Over time, you try to empty your brain of any thoughts. Again, that's hard to do. It takes practice. But over time, you actually decrease your sympathetic, your adrenaline response. Meditation. All of the things I'm talking about here have to be practiced. You can't do them once and have them work. It's a little like a martial art. You practice it over and over and over, and when a situation arises, you do them automatically to protect yourself. Guided imagery, we spoke about this before a little bit. The health professional guides the patient to envision a relaxing situation. The person can learn to do this on their own. So your therapist says, you're at the beach, it's a beautiful sunset, you're relaxing, you're walking your dog. So it's guided imagery. Another technique is called stress inoculation. Teach the patient how to use positive self-talk. Something like, I can handle this, I've been through worse, I can do this, and when I'm done, I'm going to reward myself when I succeed. All of you do that, I'm sure, during a test. You say, okay, calm down. I can do this. I've studied. I've been through worse. So it's stress inoculation. You're preparing yourself for this stress and to get through it. So let's go back to acute anxiety. It is best treated with cognitive behavioral techniques as opposed to psychodynamic. So when someone's having an acute anxiety attack, they're not going to tolerate laying on the couch and talking about their childhood. We want to use very concrete cognitive behavioral techniques to decrease their anxiety, to cope with it, things like that. Okay. Again, meds can be added if the person is too anxious to function or practice these techniques. But what we don't want to do is give a patient a medication every time they come up and complain of anxiety. Because what we might be doing is creating a drug addict, or what we're telling the patient is you can never solve your problems. You will always need help from somebody else or help from this pill to solve your problems. What we really want is have that person to be able to control their anxiety on their own. That creates a sense of self-efficacy and confidence. They feel accomplished that they can control their emotions. So again, medications can be used, but they're a last resort. I think I told you a story of a patient who came to the front desk demanding a Valium. I said to him, what's the matter? Let's sit down and talk. He did not want to talk, and he had an addiction problem, and he actually tried to hurt me because I would not give him his Valium. Now, I would have given his Valium after we had talked, and if that talking didn't calm him down. But I have found 90% of the time when somebody comes up to the desk and says, I'm anxious, I'm upset, sitting down with them and talking to them and giving them 10 or 15 minutes of your undivided attention, they calm down much better. Okay, again, we can use benzos and medications, but we don't want to use it as a first line. We want to talk to them and listen to them first. Okay. let's talk about the nursing process here. First thing we want to do is establish if the signs and symptoms of anxiety are not cardiac. Again, if this is a heart attack, this is deadly serious, okay? So assume it's a heart attack until you prove otherwise. These patients are commonly seen in the ER or the LIP office, and LIP is licensed independent professional. Hold on one second. Can you, let me get back here. Where was I? So I said LIP, licensed independent professional, and I say that because nurses are licensed independent professionals. We should be very proud of that, okay? So let's see. They come into the ER with sympathetic response, churning out adrenaline. The patient, they think they're physically ill. What are you going to do? You're going to put them on oxygen. You're going to perform an EKG. You're assuming it's cardiac because the symptoms of a heart attack are similar to the symptoms of severe anxiety. Okay, how do we assess for anxiety? Well, we're going to do an EKG, okay? If you're having a heart attack, chances are your EKG is going to be abnormal. We can ask them or assess for certain things also. Urinary frequency. Does the person say, I have to go to the bathroom? Okay. Do they have twitches or tics? Are they stuttering and stammering? How is their eye contact? We know people that are anxious tend to have poor eye contact. Are they blushing? Is their face red? You know, when I first started teaching many years ago, I would stand in front of the class and I would probably blush because I was very nervous. Now that I've done this many, many times, my anxiety is quite a bit decreased. Okay, we can ask them about substance abuse patterns. Are they doing any stimulants? For example, cocaine, coffee, things like that. We know that they can increase anxiety. Why? Because we know that they increase the release of adrenaline and dopamine. Both of those neurotransmitters are excitatory neurotransmitters, meaning they turn on the postsynaptic nerve. Another thing we can look for is indecisiveness. They come in the room and they don't know where to sit or what to do. And we might have to say, you can sit in this chair right over here. Well, again, questions we can ask the patient. Do they experience sudden fear? Do they ever feel they're unable to escape? Do they worry a lot? What do they worry about? Do they have any special routines? And we're assessing here for OCD, right? That they have to check the doorknob 5 times and comb the hair 6 times to the left. They have a certain routine they have to go through. Do they have a history of trauma? Has anything happened recently traumatic? Are they nervous around people? Again, how many close friends do they have? Most of us have 2 or 3 close friends, our significant other, and 1 or 2 other close friends. Most of us don't have 10 or 15 very close friends. That would probably be more a manic symptom. Okay? Okay, let's see what we got here now. Assessment tools for anxiety. Again, there are many assessment tools to assess for anxiety. The General Anxiety Test, the Hamilton Anxiety Rating Scale, these give us numerical values on a test. Okay, so there are ways to measure things numerically. What nursing diagnosis would apply here? And again, anxiety, powerlessness, fear, social isolation, ineffective coping, post-trauma response, that's nurses PTSD and nursing language. Nursing outcomes. Again, the outcome is when you're doing a care plan, what do you want to achieve? Well, we want to reduce the signs and symptoms of anxiety. So chances are you want to get rid of the data that got you to this nursing diagnosis. Okay, getting rid of sweatiness, increased pulse, stammering, things like that. Maybe the person can connect anxiety to unresolved conflicts. They realize that the reason why they're afraid of dogs as an adult was because they were bitten by a dog as a child. Maybe the person can learn to demonstrate coping techniques such as deep breathing, meditation, things like that. The person can learn early warning signs of anxiety. That is the best time to intervene. You don't want to intervene. Well, it's more difficult to intervene in anxiety when the person's in a full-blown panic attack. When they can learn when it's coming on, they can practice some of these techniques such as medication to decrease that anxiety. The person realizes the importance of taking meds. One of the problems with the medications is, particularly the SSRIs, is they feel so natural that people don't take them. They say, well, the meds aren't working because I feel so good. And my response to that is, you feel so good because the meds are working. Don't stop taking them. Are they able to socialize with decreased anxiety? That's a very good indicator that they can be around other people without being overly anxious. That would be a desired outcome or goal that we'd want to achieve. Nursing interventions. What do we do as nurses? Well, as in all of this, we assess for suicidal ideation and plan. Okay? If the person has suicidal ideation and a plan that could be achieved on the unit, you're going to put them on one-to-one. One-to-one means a nurse's aide or a nurse is going to be within arm's reach of that patient all the time. If you do this, you have to write a note as to why you've done this. You have to call the doctor. The doctor comes up, reads your note, interviews the patient, and then writes the order. If he doesn't agree with you, saying, no, I can't do this, whatever, at least you've done your due diligence. Okay? Well, remove the client to the area with decreased stimulation. If there's a lot of commotion and somebody's anxious on the unit, we want to get them to a calmer area. In fact, those of you who have been on the detox unit at the hospital, you notice the detox unit and the psych ward too are very calm. People coming off of alcohol are prone to anxiety. If you remember, anxiety is a calming drug. The opposite tends to occur in acute withdrawal, so they're more prone to anxiety. So we want to keep the detox unit very, very calm. We want to stay with the client during this acute phase of anxiety. They're nervous, they're possibly panicking. We don't want to abandon them. We sit down with them calmly, and if we have to spend 20 minutes with them, we do that. Okay? We want to communicate calmly and clearly because we know when people are anxious, they're not processing what's going on around in their environment as clearly, so we want to be very calm and clear. The more anxious a person is, the more directive we become. Like I said, when people's anxiety increases, their ability to focus on things decreases, which means we have to become a little more directive to them. We want to teach them relaxation exercises. Again, they can't be done at once. They have to be practiced over and over, and it becomes a tool the person can depend on should this anxiety crop up. Administer a PRN. PRN means as needed. Okay. I like to think of PRN meaning as per patient request. Med only after verbal attempts have failed. So we try to calm the patient down verbally. We might want to teach them relaxation techniques, but if they don't work, we can give them a benzodiazepine. In this case, an SSRI would not work because if you remember, SSRIs take several weeks to work, where a benzo works probably within 20 minutes to a half an hour. We want to educate the patient to use relaxation techniques at first sign of anxiety. Again, you don't want to wait until it's full-blown anxiety. It's not going to work as well. As soon as they notice the anxiety coming up, they can use these techniques that we've taught them. We want to assist the patient in identifying stressors in their life. If they're going to work every day and work is simply too stressful, we might want to help them explore different areas to work. Again, going to work every day and being under stress, you can give them benzos forever, but it's not going to get rid of the cause. Help the patient develop a plan to reduce stress by making a list of problems and solutions. So many times, life's little problems add up to be one big problem. We can sit down with the patient and make a list. What are their concerns? What are their worries? And we can write down solutions or collaborate with the patient on ways to solve those problems. We also want to teach the patient about medications, how the medications work. That's called the action of the medication, the side effect, and the importance of compliance. Okay, very important. We want to also educate the patient on avoiding stimulants. There's no sense in giving somebody a benzo for anxiety if they just had 8 cups of coffee. We want to have them reduce that coffee, and I would say anybody with an anxiety disorder should probably not be having 1, maybe 2 cups of coffee a day. Maybe they can switch over to tea. Tea has less caffeine than coffee. We want to encourage the verbalization of fears and symptoms of anxiety. Okay? We want to emphasize there is no shame in anxiety. Many people feel ashamed by anxiety. Anxiety is not bad. It happens to humans. Okay? We also can educate the patient that anxiety is distressing, but it's not dangerous. Yes, you may feel like you're having a heart attack. We've checked you out. You're not having a heart attack. It is distressing to you, but it's not dangerous. You're not going to die from this. Conclusion here. We want to assess the patient's level of anxiety. Are they relaxed? Are they in moderate anxiety? Or are they in full-blown panic? We want to assess our own level of anxiety because we know anxiety is contagious, especially if the caregiver themselves is prone to anxiety. They have to be even more aware of where they're at on the anxiety continuum. We want to do direct observation as indicated. Again, if somebody's very anxious, we want to keep our eye on them because anxiety can result in suicide in some cases. Okay, we don't want to abandon our patient. We want to keep the environment calm, reduce stimuli. We want to use verbal interventions. We want to teach relaxation techniques. And in the final analysis, if none of these things have worked, we can give the patient a benzodiazepine or some other anti-anxiety agent. Again, it wouldn't be an SSRI because SSRIs have a lag time of about 3 weeks to a month to work. So a benzo or an antipsychotic such as Geodone or Haldol sometimes will help with anxiety. Okay, I want to thank you. I think we've got done with this anxiety lecture. Hopefully we're all good, and I will be doing another one and posting it shortly. Thank you very much.